So the levels of CO2 coming back to the patient on the inspiratory part of it start incrementing. That's what you're monitoring. What the gases go.
In that situation, would they have enough time to actually be able to replace the absorbers if they had to replace them? Using something like
Yes,
this?
I can do it.
Or would they have to manually?
Yes, I can do it. All you have to do.
Is there enough time?
Normally, manufacturers make that door large enough where you can have two of these packs always there.
Just in case.
Or at least one. It's easy enough to open, pull, take one out, put another pack in here, close it.
It's all in one breath.
One or two breaths, okay? And it's done. But still, what if they didn't have this? What if the practitioner, when he took this off, threw it on the floor and dropped it and broke it? Whoa, we lost an anesthesia machine. That's why you have to have a crash cart and you have to have an ambu bag. Okay. Medical profession nowadays looks upon you guys to tell them how many other ways they can back themselves up from going into a crisis situation. Why do we have a defibrillator with a monitor on a crash cart? And we have drugs to reverse almost anything. And why do we have in that same crash cart an ambu? Why do we have an oxygen tank hanging on the outside of the ambu, that crash cart? That crash cart, if you have a code, you're supposed to be able to go there and have everything at your disposal to bring that patient back. Nowadays, they're talking about putting a first run ventilation on that cart, putting a, what they call a transport ventilator on a crash cart. I don't know if it will eventually go into that convention or not, where they don't want the practitioner to have to worry about giving CPR because they have other things that they need to do while they can intubate the patient and go. Okay? So, as you can see, when we were at the inception of this, they only had one device, and if it worked good, man, we had the chance of getting that patient over that hump. That's why operating room safety 40, 45, 50 years ago was a pull of a gun. Either you hit or miss, okay? As we have gone into getting more reliable equipment, people that are trained that will be able to determine that a piece of equipment is starting to fail. That is the most important thing that you could do. Seeing a device that when you calibrate it here, 4 months later it comes back to the shop. Oh, it drifted. Why did it drift? How come it's not holding its thing? That's where you are going to grow in this business. When you're able to determine those and make these devices that much more reliable. Okay? On here, they have, on this machine, they have an alarm panel. The monitoring is up here. On this one, the alarm panel and the monitoring is on the side here. The ventilator is up here, and it has some alarms. On this one, the ventilator has an inspiratory flow, it has a ventilator switch, and it has some other adjustments, okay, which are inspiratory to expiratory ratio. When you breathe, you don't go. You have different, people have different ways of breathing. You want to be able to accommodate the machine to mimic what the practitioner sees on the patient before he puts them under. Because if you do it the same thing for 4 hours in an operating room, the body does not accustom themselves to breathing differently. They will go back a lot easier to their normal breathing if they have been kept the same way. And that's, it's been found